we go ahead, Prof. Muhammad.
Okay. Good evening, everyone. It's a great pleasure to be with you today in this series of lectures organized by the Saudi Society of Hematology. Tonight, we have a very special occasion and a very important panel of discussion, including Professor Mark Crowther from McMaster University in Canada. We have a panel of experts, both Dr. Ashraf Warsi, Assistant Professor of Hematology, and the Consultant Hematologist from National Guard Hospital in Saudi Arabia, in Jeddah. And we have on board my colleague, Dr. Ahmed Barifa, again, a Consultant Hematologist and Assistant Professor of Hematology. And a very special topic for tonight is the vaccine-induced thrombotic thrombocytopenia. You know, I'm in the middle of this third wave or crisis of COVID. It's very important to cover this important aspect, and I'm sure the discussion is going to be very rich. I would like now to invite my colleague Dr. Ahmed to introduce our eminent speaker. Thank you.
Thank you, Prof. Muhammad. Welcome, everyone. And it's my great honor and pleasure to introduce one of my dear mentors, Prof. Mark Crowther. He is the chair of the Department of Medicine and Faculty of Health Science in McMaster University. He holds also the Leo Pharma Chair in Thromboembolism Research in McMaster University. He is a professor in Department of Pathology and Molecular Medicine, professor in Department of Medicine, and professor in Department of Clinical Epidemiology and Biostatistics, and the chair of board directors of St. Joseph Healthcare System International Outreach Program. He is a well-known researcher and in the hematology and thromboembolism. He's the co-chair and senior research committee of Heart and Stroke Foundation of Canada, and also the treasurer of American Society of Hematology. He has published more than 530 peer-reviewed articles and has a total citation of more than close to 70,000 citation as of December 2020. So we're very happy to have Dr. Mark Crowther with us today, speaking to us on a very important topic, vaccine-induced thrombotic thrombocytopenia. We'll pass the mic to Mark. So go ahead.
Great, thanks very much. I'm just going to share my screen here. Just 1 second. Thank you for the introduction, for the kind introduction, and thanks for the opportunity to speak. I'll just get Ahmed to indicate with a thumbs up if he can see my screen. Can you see my screen?
Yes.
Perfect. All right, thank you. So I'm going to talk, I've expanded the talk a little bit. So I'm going to talk about thrombosis and COVID-19 first. Then I'm going to talk about VITT in the second part. And the reason for that is that one of the facts that people are getting really very confused about is the importance of thrombosis associated with VITT, which is an unimportant problem compared with thrombosis associated with COVID-19, which is an important problem. So first 10 or 15 minutes will be on thrombosis with COVID-19, then the rest will be on VITT, and there will be lots of time for questions. I've left lots of time because there's a great deal of questions. I will say that about a half hour ago, I was on the phone with our nephrology colleagues because we have a 40-year-old woman in the ICU at the Hamilton General Hospital who had a large stroke from VITT and is going to die from it. And the question is, can she donate organs? And that gets the news because people say, oh my goodness, here's a 40-year-old who wouldn't have had a need to even talk about organ donation if she hadn't had the AstraZeneca vaccine. But what isn't talked about is the fact that in Hamilton right now, we have about 60 people in our ICUs, of whom about 40 are ventilated. And of the ventilated people, more than half will die. And in the province of Ontario, we've recently had an 18-year-old and a 20-year-old die from COVID-19. And so, you know, it is the bottom line with respect to vaccine-induced thrombotic thrombocytopenia is that it's a serious medical condition, but we're in the middle of a pandemic, and sometimes you need to do things in a pandemic that you might not do under ideal circumstances. So I do have conflicts of interest. None of them are relevant to this presentation today, but I do present them all. I work with companies that make both anticoagulants as well as anticoagulant reversal drugs. So I'm going to talk a bit about COVID-19 associated thrombosis and VITT associated thrombosis. I'm going to talk about VTE in hospitalized patients with and without COVID-19, and then list some of the potential strategies for prevention of COVID-19 associated thrombosis, the most important of which is vaccination. Then we're going to talk about the treatment. So we're going to discuss VITT, or thrombotic thrombocytopenia, and its potential treatments as well. So thrombotic manifestations in patients with either COVID-19 or vaccine-induced thrombosis, thrombocytopenia syndrome are the same. So with VITT, what's getting the news is that patients suffer splanchnic vein thrombosis or cerebral vein thrombosis, which are both unusual sites of thromboembolism. And you might think that VITT is characterized by just very unusual site thrombosis, but in fact, the most common sites of thrombosis in patients with VITT are in usual locations: deep vein thrombosis and pulmonary embolism. Certainly they do suffer arterial thrombosis, they do suffer thrombosis in other locations, but the most of the cases are going to be deep vein thrombosis and pulmonary embolism. We've had a total, I think, of 4 cases of VITT in Hamilton now, and the first 2 presented to my hospital, both with pulmonary embolism, and were treated almost exclusively as outpatients and did really well. Another characteristic of COVID-associated thrombosis, not so much of VITT, but could occur with VITT, is line or device-associated thrombosis. And then with COVID, we have microvascular thrombosis of the lungs. We have stroke, which occurs with both VITT and with COVID-19. And then unique to COVID-19 is this issue of COVID toes, which are, we think, due to microvascular thrombosis involving the toes, or the distal fingers and toes. All right, so Virchow's triad describes why thrombosis occurs. It occurs as a result of endothelial injury, hypercoagulous and circulatory stasis. We're all aware of this. And we rarely see a case of thrombosis where we don't invoke Virchow's triad. And of course, with either COVID or with VITT, you're going to see vascular injury, and also you're going to see hypercoagulable states. The mechanism of hypercoagulability in COVID-19 is not really clear. I'll show you a slide on it in a second. The mechanism of thrombosis in vaccine-induced thrombosis and thrombocytopenia is actually well known, and it is due to platelet activation in a way that's exactly analogous to heparin-induced thrombocytopenia. Also, patients with either syndrome have immobilization, particularly if they're hospitalized, and endothelial activation can occur both as a result of cytokine storm, but also as a result of things like catheterization, highly prothrombotic surfaces. People on ECMO, for example, suffer a high rate of thrombotic complications, and inflammation associated with the infection or with the VITT reaction itself. So for COVID-19, there's pretty good models now on why thrombosis occurs. This is taken from JAMA last year, but essentially it's all related to the cytokine storm. In COVID-19, you get endothelial injury and activation, and as a result of that, you get thrombosis formation on top of sites of vascular injury, which then leads to blood clotting complications. And in COVID-19, the cytokines that are released, there's many more procoagulant than anticoagulant ones. So the procoagulant ones are listed on this slide. The anticoagulant ones are listed on the right-hand side. And in almost all patients with severe COVID-19, thromboembolism is a high-risk situation. I'll show you data on that in a second, simply because of this unopposed cytokine storm. So an important risk factor is the risk of COVID-19 associated VTE is related to the severity of the illness. And if patients are non-hospitalized, they have a low risk of VTE. We did a study of about 6,000 patients from New Orleans, showing that patients who were never admitted to the hospital have a very low risk of developing venous thromboembolism. In our study, it was 0.14%. And then there is some patients who will be in the hospital, not have venous thromboembolism, go home and develop VTE. Then there's patients with moderate illness, patients who are admitted to the wards. We'll talk a bit more about them in a few minutes. And then we have the patients with critical illness who have a high rate of venous thromboembolism. Not only do they have a high rate of VTE in the legs and in the lungs, they also have a high rate of complications due to clotting of catheters, et cetera. And we know a lot about the risks of thrombosis in patients with COVID-19. This is a systematic review, which was published a couple of months ago. And this is the forest plot, which these are all studies of thromboembolic rates in patients with COVID-19. An immense number of studies have been published, considering we've only known about this disease for a year or so. In patients with COVID-19, the overall estimated rate of VTE is 17%. And so this is a really important thing to remember when you're talking about VITT. The rate of VITT, as I'll show you later, with AstraZeneca is maybe 1 in 25,000. It may be 1 in 50,000. The rate of VTE with COVID-19, as you know in Saudi from your initial experience a year ago, is thousands of times higher than that. And probably the most important thing to remember about VITT is the FDA stated that the risk of thrombosis associated with VITT is, they said, 70,000 times lower than the risk of thrombosis associated with COVID-19. And so when people talk to me and they say, I don't want to get the AstraZeneca vaccine because I'm afraid of getting a blood clot, I tell them that's actually makes no sense, because if you don't get vaccinated, you're going to get COVID-19. If you get COVID-19, you have a very high risk of developing venous thromboembolism. There's just nothing we can, the math is so clearly in favor of getting the first available vaccine. People oftentimes forget that. But in my hospital right now in St. Joe's, I think we have about 40 admitted COVID patients between the ICU and the wards, and probably a third of them have had one or more episodes of venous thromboembolism. If you look at patients who actually made it to the intensive care unit, the risk of them developing venous thromboembolism is even higher. It may be a third. And if you look at the studies that have contributed to this analysis, even if you look at studies that used a clinical suspicion of venous thromboembolism followed by testing, the estimated rate of VTE was 10%. So it's really important that people remember that VITT, although it's an important complication of vaccination, is very rare. And venous thromboembolism in COVID is very common. And so the argument is really hard. We have lots of people in Canada who say, I'm not going to get vaccinated because I'm worried about having VITT. And it just makes no sense. Remember also that if you have a patient who has venous thrombosis due to COVID-19, they are going to be treated with anticoagulants. And if they are treated with anticoagulants, they have a high risk of developing bleeding. In fact, in this analysis, the rate of clinically important bleeding was 10%. The actual, if you look at studies that I'll show you in a second, which looked at higher doses of anticoagulants, for example, therapeutic dose heparin, the rate of bleeding is even higher than that. So again, the discussion about VITT is always colored by this perception of an avoidable complication. Oh, if I don't get vaccinated, or if, I don't get AstraZeneca, I won't develop this complication. Sure, but if you don't get vaccinated, you're at high risk of developing COVID-19. And if you develop COVID-19, your risk of developing venous thrombosis or the complications of venous thrombosis is thousands of times higher. So this is a study that we did in New Orleans. We enrolled 6,153 patients who had PCR, 6,153 patients that had COVID-19 proven by PCR. And of those patients admitted or seen in an emergency department in New Orleans, 7.2% of the patients who went on to be admitted to develop critical illness and require mechanical ventilation, 7.2% of them had a deep vein thrombosis or pulmonary embolism. But as I said earlier, if the patient survived the hospital stay and went home, the risk of developing venous thromboembolism was really low. We had 4 patients, or less than 1%. If patients were never admitted to the hospital, they had a risk of 0.14%. So the risk of venous thromboembolism in patients with COVID-19 is largely confined to hospitalized patients. And further, it's largely confined to patients with critical illness. If a person does develop venous thrombosis in the setting of COVID-19, it is there's a high rate of heparin failure. So 50% of the clots in our study occurred in patients who were on recommended dose of anticoagulants. And that's why there's been studies, which I'll present in a second, looking at intensified prophylaxis. And so when you're talking about thrombosis in COVID-19, just remember again, the risk of thrombosis is really high, particularly if you're hospitalized, and it vastly outweighs the risk of vaccine-induced thrombocytopenia. Just one slide I put in to talk about risk prediction models. This is for venous thromboembolism in general, and patients with COVID-19 generally are in the high risk designation for this. So a question that we're asking now in patients who have COVID-19 is, should they receive standard intensity prophylaxis or higher intensity prophylaxis? And this is critically ill patients. And so Adam Suker, who's noted at the bottom here, some of these are his slides, published this in Blood Advances, that if you look at patients who are critically ill in the ICU with COVID-19, that the estimated absolute incidence of proximal DVT and PE is reduced by therapeutic anticoagulation, but that is more than offset by an increase in the risk of major bleeding. And the risk of mortality is really iffy, although the estimate is 52 fewer per 1,000 patients. In fact, the confidence intervals widely span risk and harm. And so we generally are now recommending against the use of therapeutic dose anticoagulation for prevention of VTE, not for treatment. This is for prevention of VTE in critically ill patients. And again, just to remind you that there are many studies going on right now looking at the use of anticoagulation in COVID-19. There's more than this. This is just a selection of them. And so as time passes, we will get more and more data on how we should be managing COVID-19. One of the really interesting things that's happened from COVID-19, and I'm sure you've had the same experience in the Gulf as we've had here, is that this pandemic, the treatment of it is being guided by press releases rather than science. And you'll see this in VITT, that people's perception of the importance of VITT is driven by the consequences of the newspapers, the media's perception of what's going on, not reality. So when this study was announced here, which is the study of high intensity versus standard intensity anticoagulation for prevention of venous thromboembolism in the ICU, it wasn't released as a paper, it was released as a press release, which then got into the major media. And this starts to breed this concept in patients' minds that there's something wrong with anticoagulation, that breeds the concept there's something wrong with vaccines. And we really shouldn't be doing science this way, but for some reason with COVID-19, we are now being guided a lot by anecdote and case report and media stuff, not by good quality science. The other thing that's come out of COVID-19, which I know you're all familiar with, is that we used to have to wait until a paper was published, but now there's this push to use these preprint servers. So essentially what happens is the authors submit their paper to a preprint server. It is placed there, the world can look at it. It hasn't been properly reviewed. We don't know if it's good quality science. And in fact, the paper that I'm going to present next, which is looking at the prevention of clots in patients who are medically ill but not in the ICU, has not actually even been published yet. It's still on a preprint server when I checked just a couple of weeks ago. So this is an open label adaptive multi-platform, that means multiple randomized controlled trials of COVID-19 patients who don't require critical care, and they're randomized to get therapeutic dose anticoagulation or usual prophylaxis. The trial was stopped when the criteria for superiority were met, even in patients with either a high or low D-dimer. And basically what this study said is that in non-critically ill patients with COVID-19, initial therapeutic dose anticoagulation with heparin increases the probability of survival to hospital discharge with reduced use of organ support, which then led to a lot of buzz on Twitter. So Ryan Zarechansky is the principal author of this paper, and he's in Winnipeg. And so rather than having a peer-reviewed journal article to spend some time thinking about, when we're trying to decide what we should do to prevent VTE and HIT in COVID-19. We're left trying to figure out whether this preprint on a preprint server or this Twitter comment is actually what we should be using to guide therapy. And of course, neither one should be what we're using to guide therapy. But again, we have this paper which suggests that therapeutic dose anticoagulation is superior to usual dose anticoagulation for prevention of clots in hospitalized non-critically ill patients, and that leads to more press releases. So the National Institute of Health on January 22nd released this press release, and so now all of a sudden we're trying to figure out what's fact, what's not fact, and how we can manage patients with COVID-19 or complications of vaccines in the setting of patients getting all this news through the news media without it being properly reviewed. So this brings us to a case before we start to talk about VITT. 62-year-old male admitted to hospital with COVID-19 requiring 3 liters of oxygen, classic chest x-ray and inflammatory markers, normal kidney disease and liver function. What dose of anticoagulation prophylaxis should this person get? And there's no standard about this. And the reason there's no standard is that although we have good quality evidence from a single large randomized controlled trial that these patients should receive therapeutic dose anticoagulation, that paper has not yet been peer reviewed or published in a peer reviewed journal. And so people have a lot of hesitation about embracing it. I'm only going to touch on treatment of venous thrombosis with COVID-19 in one slide because it's not particularly complicated. In fact, it's really quite easy. Objectively confirmed VTE in COVID-19 patients should be treated in a manner analogous to patients without COVID-19. Critically ill, unstable patients should probably receive IV unfractionated heparin titrated to the PTT or therapeutic dose low molecular heparin. But again, these patients can be highly inflammatory, have a cytokine storm. And if they do have a cytokine storm, then you can get into a situation where the PTT is unreliable. So you need to keep half an eye on that. Stable in or out patients can be treated safely with a DOAC. And the duration usually will be 3 months and then it can be stopped. There's all kinds of great information right now from various organizations on how you should manage both thrombosis and COVID-19 as well as VITT. I would encourage you to look at some of these resources. So Thrombosis Canada is a peer organization that has a lot of great information on its website about thromboembolism and COVID-19. It has a whole section on vaccine-induced thrombosis and thrombocytopenia. So I would encourage you to just type into your search engine, Thrombosis Canada, it'll take you to the site. And the resources are available free for download. Watch the American Society of Hematology website. They have a lot of information. They had some great webinars on vaccine-induced thrombosis and thrombocytopenia. And also the Anticoagulation Forum, or AC Forum, is another US organization that has lots of great information. And I'll start talking about VITT right now, but what we've discovered in COVID-19 is things move so fast that in a week, what I say today may not be relevant. The only way you're going to be able to keep up to date on what optimal treatment is to look at information which is being broadcast by some of these organizations like the American Society of Hematology, like Thrombosis Canada, or like the Anticoagulation Forum. So VITT, or vaccine-induced thrombosis and thrombocytopenia, or TTS, thrombotic thrombocytopenic syndrome, or VIPIT, which is vaccine-induced procoagulant and immune thrombocytopenia. And again, VITT is a very rare complication of vaccination with adenoviral vaccines for COVID-19. And it is far less common than thrombosis due to COVID-19 itself. So this is a headline you can see on the left-hand side of the screen from the CBC News on May 25th. Ontario reports first death of rare blood clots linked to AstraZeneca. And then if you read down below, province reported 41 more deaths on Sunday and Monday. So what the news media chooses to focus on is this one death to AstraZeneca. And then in a little subtext down below, it points out that 40 times as many people died in the last 2 days from COVID-19. Thousands and thousands of patients have died in Ontario from COVID-19. One has died from AstraZeneca. So again, the risks of VITT are very small. So the summary of VITT, I've got quite a talk about it, but just to give you the summary first, VITT is a very rare complication, and it appears to be isolated to adenoviral vaccines for COVID-19. It's not been reported with the mRNA vaccines or any other technologies. Remember that the risks of thrombosis from COVID infection vastly outweigh the risk of vaccination. We've known for many years, although we didn't have to put it into practice, that in a pandemic, the most effective strategy to reduce the risk of thrombosis, including CSVT and splanchnic vein thrombosis, is to vaccinate people with the first vaccine they can access and they are eligible for, because you're going to reduce the frequency of the COVID-19 in the population, which is going to reduce the complications of COVID-19. So if you want to reduce the number of cases of CSVT and splanchnic vein thrombosis in Saudi Arabia, the way to do that is not to use an adenoviral vaccine. It's to vaccinate everybody with the first available vaccine and reduce the frequency of COVID. And I'll show you some evidence for that in a second. We've got lots of patients in Canada who tell me that they're waiting for the mRNA vaccine to become available for their age group. And what they don't realize is that if they do that, they're going to have a higher rate of suffering CSVT or splanchnic vein thrombosis because they'll get COVID. So should we use the AstraZeneca vaccine or the J&J vaccine or the Sinopharm vaccine or the Sputnik vaccine? And the answer to that question is absolutely yes. And I don't need to say anything else more on this slide. This is data on new cases in the United Kingdom, which was updated a couple of days ago from the Johns Hopkins website. So in the United Kingdom, you're probably all aware, the treatment strategy is a first dose strategy. So they're dosing everybody with the first dose and then doing the second dose in a delayed fashion, which is what we're doing in Canada. And in addition, 60% of the vaccinations in Britain are AstraZeneca. And this is the frequency of new cases in Britain. You can see that it peaked out at just less than 1,400 per day in January of this year. And now their rates of new cases and deaths are dramatic. Sorry, that was deaths, 1,400 deaths. Over the last few days in Britain, they've averaged between 3 and 5 deaths per day. So they've reduced their rate of death from COVID-19 by many hundredfold. And they've done that predominantly by using a vaccine. If the vaccines were causing high rates of thromboembolism and death, the numbers wouldn't have fallen like this. And so when people ask me in Canada, are you comfortable with AstraZeneca? The answer to that is absolutely yes. My wife got her first dose of AstraZeneca back in April, and when she becomes eligible for her second dose of AstraZeneca, she will go and get it, because that's the way to prevent us from getting her from having a high rate of developing venous thromboembolism. And again, just to compare and contrast, knowing what I know, it turns out that in Canada since 2018, 555 Canadians have died riding all-terrain vehicles. And in Canada so far, 3 people have died from VITT. So again, we've got our perceptions all messed up around the frequency of this complication. Would people ask me, would I be comfortable getting the AstraZeneca or Johnson & Johnson vaccine if I hadn't previously had a vaccination? The answer again to that is absolutely yes. And you'll see here a headline from the 21st of May that Ontario moving ahead with second doses of AstraZeneca vaccine. So they've come to the sensible conclusion in Canada that the best way to prevent venous thromboembolism is to vaccinate everybody and use whatever vaccines we have available. So let's talk specifically about what VITT is. Back in February 2021, investigators in Britain, Germany, Austria, and a couple of other countries noted the development of a highly prothrombotic syndrome in a small fraction of patients who received the AstraZeneca vaccine, which is manufactured in Britain or by the Serum Institute of India. It's an adenoviral vector-based vaccine, as I said, and it has also been seen at a substantially lower rate with the Johnson & Johnson vaccine. The Johnson & Johnson vaccine, the rate is probably around 1 in 200 to 1 in 400,000. The AstraZeneca is probably on the order of between 1 in 50 and 1 in 100,000. It has all these other names that I mentioned earlier: vaccine-induced immune thrombotic thrombocytopenia, or thrombosis with thrombocytopenia syndrome, or vaccine-induced prothrombotic immune thrombocytopenia. And we seem to be moving to VITT as the standardized term. And here's the paper, which was published April 9th. Andreas Greinacher from Germany was the primary author of it. The exact incidence of VITT is unknown, but it appears to be really rare. Again, 1 in 100,000 to 1 in 25,000 for AstraZeneca, 1 in 250,000 with Johnson & Johnson. I believe both the Sinopharm and the Sputnik vaccine are adenoviruses. One presumes that they have VITT associated with them, but I've not heard any rates published about that. And remember that the reason why I'm able to tell you that there's a woman in the intensive care unit at the Hamilton General right now with VITT is not that VIT's common, it's that millions and millions of people have been vaccinated. In Ontario, 825,000 people have received the AstraZeneca vaccine. So, you know, even rare complications are going to crop up. Why does this occur? It's an autoimmune phenomena. A very common question I get asked is, you know, this patient has factor V Leiden or they had previous venous thromboembolism. Does that increase their risk of VITT? Absolutely not. VITT is not a thrombotic problem. It's an auto-antibody driven problem. The clinical manifestation is thrombosis, but it's driven by an autoimmune process. So prior history of thromboembolism doesn't increase your risk of developing this complication. And these antibodies activate platelets as a result of binding to the platelet FC receptors on the surface of platelets. So what is VITT? VITT is this autoimmune reaction where an antibody to platelet factor 4, or PF4, is able to activate platelets and cause diffuse procoagulant state, which is associated with venous and arterial thrombosis. Although they haven't received heparin, the disorder is very analogous to heparin-induced thrombocytopenia. And to some extent, we're treating these patients as if they have heparin-induced thrombocytopenia, even though they don't. What are some of the characteristics? So this is a really important slide. This is data from a paper published, or a letter to the editor published in the New England Journal on May 19th. And if you're interested in diagnosis of VITT, I would suggest you have a look at this paper. So I'm hoping you can see this fairly clearly, but in panel A, one thing that's really important to remember is that there's a whole series in North America of approved point of care tests for HIT. These are bedside or near patient tests, and they miss the diagnosis. So the bedside or point of care heparin-induced thrombocytopenia test cannot be used to test for VITT because they routinely are not sensitive. And so this is two commonly used point of care tests are the Stick Expert HIT test and this Hemocell Accustar HIT IgG point of care test. And in 9 patients who were proven to have VITT, none of them had a positive test with these rapid tests. So the rapid tests are essentially not useful. In panel B are the results of standard ELISA assays. And so there are standard ELISA assays which are run in the laboratory for heparin-induced thrombocytopenia. If you look at the first of the panel, first third of the panel in panel B, a standard PF4 heparin ELISA, it was positive in the 9 patients and 5 of the 9 patients. And then you look at the right-hand side, if you modify the assay a little bit so that it includes PF4 that's immobilized on polyvinyl sulfate, 7 of the 9 were positive. And so generally speaking, people with VITT have a positive lab-based ELISA test with a negative point of care test. And then you can move on to the formal heparin-induced thrombocytopenia testing. So in the bottom panel, panel C, you can see on the left-hand side, a standard SRA where as you increase the amount of heparin in the sample, the platelet reactivity drops. Most of the patients were positive in a standard SRA. But interesting enough, if you modify the SRA, the serotonin release assay, a little bit to increase the amount of platelet factor 4, a much higher fraction of the patients were positive. And so again, optimal testing may require some modification of your currently available tests. And I would advise you to speak with your laboratory professionals. I know you have some great labs in Saudi Arabia because the lab science of VITT is moving forward on a day-to-day basis. And what is true today about the standard of testing may not be true next week. And so this is an area of very, very active investigation. But the bottom line from the diagnosis is, just to go back to the slide, these are IgG class antibodies. They recognize platelet factor 4 bound to platelets. They're detectable in some ELISA assays, but not all. They're not detectable with most point of care heparin-induced thrombocytopenia assays. The mechanism of thrombosis is platelet activation, and interesting enough, they aren't heparin dependent. So this is like HIT, except the antibodies are not heparin dependent. What are the clinical characteristics of vaccine-associated VITT, thrombosis thrombocytopenia? Typical or atypical site VTE, that should say atypical VTE, occurring 4 to 30 days after vaccination. CSVT has an unusually high frequency and an unusually bad prognosis. Large vessel arterial thrombosis has also been reported, like the patient that I talked about earlier, who's currently in our ICU. The distribution of clots is very similar to that seen with other unusual thrombotic complications like paroxysmal nocturnal hemoglobinuria and the JAK2 mutation, which both have a predilection for causing cerebral vein thrombosis or splanchnic vein thrombosis. And interestingly enough, there have been cases of VITT that have presented with sudden death. Again, though, there's been lots of cases of COVID associated with sudden death. There was a thing in the newspaper this morning that in Ontario, there's now 50 cases of people who were subsequently shown to have COVID-19 who died unexpectedly at home, and they're probably suffering a cardiac cause. What causes VITT? It's unknown. It's an immune reaction, but nobody knows why this particular immune reaction. It hasn't been seen with some of the other adenoviral vaccines. As I said earlier, the CanSino and Gamaleya have not been reported to cause it, but it may be that the case ascertainment is not great. But probably the most widely used adenoviral vaccine in the world outside of COVID-19 is the Ebola vaccine, which is made by Janssen, and there haven't been any cases associated with this. So it's not a characteristic of all adenoviral vaccines. It's COVID-19 adenoviral vaccines. It's not reported with the, not reported with the mRNA COVID-19 vaccines. Earlier on, it was felt to have a predilection for younger women, particularly taking birth control pills. But that was probably actually a bias because the first people vaccinated were healthcare workers, and they tend to be young women because they're nurses. And as a result of that, there was this initial sort of flurry of activity around young women getting this complication, but people failed to notice that most people who got AstraZeneca were young women. So it may not actually have a predilection for young women. What are the clinical and laboratory characteristics? General flu-like syndrome starting 5 to 10 days after vaccination, but a lot of people who get AstraZeneca get flu-like symptoms after vaccination. My wife developed something that looked like the flu for a day afterwards. The platelet count when they present to the hospital is typically between 10 and 100,000, so pretty significant thrombocytopenia with a median reported platelet count of 20 to 25,000. But like heparin-induced thrombocytopenia, the platelet count is somewhat variable. They will frequently have a very high D-dimer and other markers of DIC, which might include a decreased fibrinogen and a normal or mildly increased INR or PTT. So key characteristics are the timing, 4 to 30 days after vaccination, receipt of either Johnson & Johnson or AstraZeneca, thrombocytopenia, and then a high D-dimer. How should you evaluate these patients? They should, COVID, first of all, every patient who presents with suspected VITT should have a COVID test because, as I've said, it's far more likely the patient has COVID-19 causing clotting complications than the vaccine. And remember that COVID-19 can cause thrombocytopenia as well. They should have a CBC done looking for thrombocytopenia, basic coagulation testing. They should have an ELISA-based PF4 assay ordered. And if your laboratory is able to do any of the modified assays that I discussed earlier, you should talk to your lab person to see if they can do that. You should send off functional testing for anti-platelet factor 4 antibodies, either an SRA or a platelet aggregation study, although those are probably somewhat less important. You should investigate for other causes of thrombosis and thrombocytopenia where appropriate. And then remember to always do imaging for suspected thrombosis. These people have a high rate of thrombosis. So if a person presents with a platelet count of 45 and a headache, you probably should image their head to make sure they don't have CSVT. How do we treat it? Well, the most important treatment is high index of suspicion. So you have to remember that if you have a patient who presents with a new headache, who had AstraZeneca or Johnson & Johnson 14 days ago, you should have a high index and a low threshold for doing cerebral imaging. We are using non-heparin anticoagulants. So in the ICU, it's probably argatroban or fondaparinux. And then in the medical ward or after discharge, a direct oral anticoagulant. We don't actually know that heparin is bad. Nobody's going to test that hypothesis. There were early cases where patients got worse after receiving heparin, but we don't know whether that was just the natural course of their illness or was due to heparin. So heparin is not known to be unsafe, but it is avoided. The patients are all getting intravenous immunoglobulin. We're not really sure if that works or not, but the idea is that you might be able to block some of these FC receptors and thus turn down the platelet activation. And we're now hearing talk about heroic measures such as plasmapheresis, but the reported effectiveness is unknown. So there's a couple of people in Toronto right now who are being plasmapheresed for refractory VITT. And as with everything else with COVID-19, we actually have available to us some pretty good resources already. And so the American Society of Hematology actually has a whole section on VITT, which I would suggest that if you're really interested in this subject, that you go to just type into Google or your best search engine, the American Society of Hematology COVID-19 guidance, and you'll be taken right there. So what are the most frequently asked questions that I get about VITT? Well, the first thing is, what's the best resource? I just pointed out that ASH has some resources. I'll also point out that UpToDate, if you have access to UpToDate, has a great COVID-19 VITT section, which is written by Ted Workington and Adam Suker. Ted here from McMaster, Adam from the University of Pennsylvania, both really big experts in heparin-induced thrombocytopenia, and both of them subsequently experts in VITT. So VITT is not caused by clotting. It is an immune phenomenon. People with a prior history of thrombosis are not at higher risk of developing VITT. Prior thrombosis, but people who've had prior thrombosis are at very high risk of getting recurrent thrombosis if they get COVID. So I get these e-consults where the person said, this person had a DVT in 1974. Does that mean they shouldn't get vaccinated? And I write back and say, no. The fact they've had a previous venous thrombosis means they're at increased risk of recurrence. They should be prioritized for vaccine. They should be the first one in line to get AstraZeneca. Prior thrombosis, use of anticoagulants, thrombophilia should not influence the choice of vaccine. VITT has a predilection for unusual sites, but probably most frequently causes unusual thrombosis. So it can cause deep vein thrombosis or pulmonary embolism, but it's been reported much more usually to cause cerebral vein or splenic vein thrombosis. The key to management is recognition and early treatment. When people are doing badly, most of them are doing badly because they present late or it takes a long time to make the diagnosis. Avoid heparin and related anticoagulants. IVIG is frequently administered, and you can use therapeutic anticoagulation in a patient who has known thrombosis, but we are, again, generally avoiding heparin. And again, the key message, the most important message is the risk of thrombosis with COVID-19 dwarfs the risk of VITT, and the clots are just as severe. So, thousands of deep vein thrombi and pulmonary embolism are going to occur due to COVID-19 for every one that occurs as a result of vaccine-induced thrombocytopenia. So take-home points, this is the last slide. Thrombotic manifestations of COVID-19 include VTE, microvascular thrombosis, and arterial thrombosis. Potential mechanisms in COVID-19 include immobilization, endothelial injury, and hypercoagulability of inflammation. Baseline risk of COVID-19 associated with VTE increase with illness severity. The best available evidence suggests that critically and moderately ill patients with COVID-19 have a several-fold greater risk of VTE than critically ill or moderately ill patients who don't have COVID-19. Post-discharge and never hospitalized patients appear to have a low risk of VTE. Critically ill patients should probably receive usual prophylaxis with intensification reserved for patients with known thrombosis. Medically ill patients who do not yet require care should be considered for therapeutic dose anticoagulation. And VITT is a very rare complication of selected vaccines that should be watched for and treated if it occurs, but it should not influence vaccine choice. You should be recommending to your patients that they get the first vaccine that they're eligible for. So I'm happy to address any questions that might come up. I will stop sharing my screen and be happy to address any questions. And I'll look right now into the Q&A box. Is it okay, Ahmed, if I just move ahead and look at some of those questions?
Sounds good. Yes.
Okay.
Do you want me to read some of them, or?
Yeah, if you do that, you go ahead. You want to moderate, and I'll just answer them. That'd be great. Thank you.
Sounds great. Thank you so much for an excellent presentation, and you highlighted a very important points throughout the slide and the presentation, and addressed most of these questions. I'll read here Dr. Hatim Al-Ahwal question and also combine it with Dr. Salwan Najjar question. For patients who have history of HIT or other immune-mediated thrombosis like antiphospholipid antibody syndrome, is there any difference in the recommendation regarding those patients?
Yeah, that's a great question. So I get asked that question a lot. So if a person had prior HIT, would it be reasonable for them to get AstraZeneca or Johnson & Johnson, or which ones do you have available in Saudi?
We had, today we reached to 13 million vaccines, more than 13 million. 4 million were AstraZeneca, and the rest are all Pfizer.
Okay.
Uh,
Yeah, I would. So I think that if you, so this is a good question. If a person has had prior HIT, I probably would avoid giving them AstraZeneca. That's about the only group of patients. If they had antiphospholipid syndrome or ITP, I would give them whatever's available to them first. And that's a question I get asked a lot. This patient has ITP. Should we avoid giving them AstraZeneca? You know, if you get COVID-19, your risk of developing COVID-19 associated thrombocytopenia is sky high. So, you know, if your goal is to prevent low platelet count, then you should get vaccinated with the first available vaccine for sure. With HIT, I would actually suggest you wait and get an mRNA vaccine, but that's about the only group. And I don't know that there's no science to that. I just think that is you know, kind of makes sense.
Sounds good. And the antiphospholipid antibodies?
I would just get first available vaccine for them. Because I think, you know, the APS, what's going to get an APS patient into trouble is getting COVID and getting admitted to the ICU and then having their heart attack or their stroke because of their APS and being in the ICU, for sure.
Excellent. Another question from Dr. Ahmed Al-Asker regarding the superior sagittal vein thrombosis. Why do you think the reason that it's more common in VET?
I don't know. That's a great question, and we get asked that a lot as well. You know, we've known for 20 years that unusual forms of thrombosis tend to seek out unusual sites. So I mentioned in the talk, JAK2 causes splanchnic vein thrombosis, PNH causes cerebral vein thrombosis, APS can cause either one of them. We just don't know. It appears that these unusual forms, you know, factor V Leiden causes deep vein thrombosis and to a lesser extent pulmonary embolism. Protein C deficient causes deep vein thrombosis and pulmonary embolism. Some of the rarer forms of thrombophilia just have a predilection for causing unusual site thrombosis. I don't know what it's due to.
Okay. And another question, few questions mentioned the D-dimer and the from the lab point of view as well, the lab technician have noticed a huge rise in the request for D-dimer during COVID. Is using D-dimer in patients with COVID as a risk for thrombosis useful for COVID-19 positive patients?
Yeah, this is a common observation. D-dimer testing is extremely useless in most situations, and it's a very non-specific marker. So the short answer is, I know that D-dimers get ordered a lot, but they are, I don't know why you would ever use them. So that if you want to screen for VITT, then the best test is a platelet count, right? Because VITT, to our knowledge, sure, there's always going to be exceptions, but the large majority of people with VITT are going to have a low platelet count. So if a person has a normal platelet count, it makes VITT very unlikely. If a patient has COVID-19 and you're worried about their risk of thrombosis, what is the best predictor of their risk of thrombosis is not their D-dimer. Their D-dimer will probably be sky high. It's whether they're in the ICU, it's whether they're on dialysis, it's whether they're on ECMO. So I can completely understand that D-dimer testing is done all the time, but it really isn't there's very few circumstances within which a D-dimer test is actually a useful test. You know, the D-dimer was introduced to allow us to rule out DVT in low risk patients, and it's being used in everybody except those people nowadays.
Okay. There is a question from Dr. Binyam Osman. He specifically asked about the study, in your study, the rates of VTE in non-hospitalized COVID-19 positive patients was very low, but small group or subgroup of patients who warranted hospitalization were not hospitalized due to various reasons, maybe at higher risk of VTE.
Yeah, so
prophylaxis those patients?
Yeah, so the answer is no, we would not prophylax those patients. So there were 2,000, so our study was a little bit special. It really only could be done in the US. I'm Canadian, but the study was done with some US colleagues. There were 2,400 patients who were seen in an emergency department or an ambulatory care clinic who had a COVID-19 test that was positive and then discharged home. And in those 2,400 patients, only 3 of them had DVT. So we conclude that outpatients are at very low risk of VTE. You know, there's this whole argument of whether hospitalized medical patients should receive prophylaxis, and you may have heard Alex Spiropoulos talk. He's a big believer in using out-of-hospital prophylaxis in these people, but the risk of that happening is actually really, really low. And it's really, really low in COVID-19 patients. So if I had COVID-19, which hopefully I won't get, and I'm never admitted to the hospital, would I take any form of prophylaxis? Absolutely not. The risks of, and the costs and the inconvenience of anticoagulating myself vastly exceed the risk of VTE.
Excellent. So another question from Dr. Benyam regarding the testing. What we have here is the ELISA, probably what all hospitals have. The SRA is not available.
Yep.
Can we depend on ELISA in the diagnosis of VITT, and what's the false negative rates?
Yeah, I think this will evolve with time, but I think you can. So the false negative rate is probably about, in that study that I presented, was about 20%. There are things that your lab can do to reduce that. And so again, your lab should be looking at whether you can reduce the stuff. It's like HIT though, that if you have a patient who shows up with who had AstraZeneca 3 weeks ago and shows up with a platelet count of 55 with no reason to have a platelet count of 55, and has a HIT ELISA that's positive, you know, what else could it be? If they haven't received heparin, it's got to be HIT. It's got to be VITT. So I'm very comfortable stopping at that point. We do the serotonin release assay because we have easy access to it, but that is really icing on the cake. The diagnosis is really established by the clinical presentation, the timing after the vaccination, the presence of thrombocytopenia, and a positive ELISA. If the ELISA, if the person presents with, you know, they've received AstraZeneca 3 weeks ago, they now have a new pulmonary embolism, their platelet count is 75 and their ELISA is negative, I would still have a high suspicion for VITT in that person, and that may be a false negative. You know, we got a call about 2 weeks ago. I got a call from the emergency department of one of our regional hospitals. You know, person showed up with a platelet count of 75, a new episode of deep vein thrombosis, and they, you know, oh my goodness, is this VITT? And I said, well, maybe. What are you going to treat them with? They said, well, he's an outpatient. We're going to treat him with rivaroxaban. I said, great. So it doesn't matter whether he's got VITT or not. And so they said, well, you know, should we blah, 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 blah. I said, can you do me a favor? And the emergency physician said, yes. I said, can you go ask the patient what vaccine he got? And so, you know, the emergency physician comes back on very sheepishly in about 5 minutes and said he got Pfizer. I said, well, you know, see, you got to get the context right? He had a platelet count of 75. He had a new deep vein thrombosis. It's not vaccine related. So it's the context. It's the right patient, the right time, the recent adenoviral vaccine, the thrombocytopenia, and then the lab testing is kind of, you know, icing on top of the cake. It's not actually going to really, it helps with the diagnosis, but it's not really required.
Sounds great. So last question, and then we'll pass it to Dr. Ashraf Warsi for his comments and questions. From Dr. Ahmed Al-Askar, he's asking, are you aware of any study that looked at incidence of thrombocytopenia alone with either vaccines?
Yeah, that's an interesting question. So that certainly, I don't know. There are such studies, and the reason that I'm very confident that there are such studies is that venous thrombosis is actually a marker that's collected on all FDA studies. So I can be we can all be 100% certain that somewhere in the bowels of the United States government is a vast amount of data on rates of VTE in patients who've gotten all of the vaccines that have filed for approval in the United States. I've not personally reviewed that data, but I have never heard anyone suggest that the vaccines, other than what we've talked about today, are associated with an increase in the risk of VTE. The problem with doing that study, particularly in the US, is that vaccine prevents disease. So any study that's done in the US where half the population hasn't been vaccinated, the VTE rates are going to be driven by the non-vaccinated patients who get COVID, right? There's going to be thousands of times as many episodes of VTE in the non-vaccinated arm because those patients in the US go on to get COVID, they go on to develop deep vein thrombosis and pulmonary embolism. So it would be really hard to figure out whether the vaccine is associated with thrombosis, because getting the vaccine reduces your risk of VTE by so many fold because it eliminates the possibility of you getting COVID.
Dr. Ashraf Warsi, he's with us.
Yeah, hi there, Professor Crowther. Thank you very much for a brilliant talk, honestly. I personally want to thank you, and as well as Thrombosis Canada, because I was one of the attendees of the meeting on May 4th, though it was at 2 a.m. by our local time. I have a question where there is some similarity between autoimmune hyperinduced thrombocytopenia and VITT. Could you, in brief, tell us a bit about that?
Yeah, absolutely. So great point. So just for those who aren't aware, so there's Ted Workington spends a lot of time working on HIT, and there's several different forms of HIT. And so the classic heparin-induced thrombocytopenia is the patient comes into the hospital, they get treated with prophylactic dose heparin. 7 days later, they develop thrombocytopenia. They have the testing, and they've got HIT. But there is a group of people who show up with a clot who have not received heparin in the recent past, and yet when you do the lab testing, they have heparin-induced thrombocytopenia, and that's the so-called autoimmune or spontaneous heparin-induced thrombocytopenia. The VITT and spontaneous or autoimmune are very similar. The only differences are that patients who have autoimmune HIT obviously haven't received the vaccine, and the antibodies are heparin dependent, whereas in VITT, the antibodies look very, very similar in lab testing. They just aren't heparin dependent. So really the only difference is heparin dependency of the two. There's an interesting underlying biological question here, and that is, why does autoimmune HIT occur? Is it due to cell surface heparan sulfates? Our cells are all covered by heparins, and it may well be, and it might be that VITT somehow the biology of VITT is in the same line. We just don't know yet. But autoimmune HIT and VITT are very, very similar, except the only real way to tell is the context, recent vaccination, and the lack of heparin dependency.
All right. And do you think the response to IVIG is also similar? I had a case of autoimmune HIT around October, November, and just after addition of IVIG, the platelets within 2 days completely normalized.
Yeah.
So do you see that in cases of VITT?
Yeah, so we know it's an interesting question. I have little doubt that IVIG will work for both. And the reason I have little doubt that it'll work for both is we know that for heparin-induced thrombocytopenia and for VITT, the mechanism of the disease is antibody binding to these FC receptors. And it makes sense to me that giving a large amount of IVIG is going to flood those FC receptors and turn those platelets off. So I have a high degree of confidence. We have not, the two cases that I've seen at my hospital were not particularly sick. We didn't actually do anything for them except anticoagulate them. I do know that in both of those patients, when we gave them rivaroxaban, interestingly enough, they both were treated with rivaroxaban, we observed the same thing you did. The platelet count rose spectacularly. Like within 72 hours, they both had normal platelet counts. And I suspect that that's a similar thing, right? With IVIG, you're blocking the FC receptor and removing the platelet activation, which causes thrombocytopenia. And when you give rivaroxaban or apixaban, you're blocking the ongoing consumptive coagulopathy, which is causing thrombocytopenia and turning it off.
Right. And regarding the confirmatory test, so most of our hospitals here, if we go ahead and we have a positive ELISA, we usually send the samples to Germany for doing the heparin-induced platelet aggregation assay.
Yeah.
Does that work in cases of VITT? I didn't see that in your slides.
Yeah, you know what? That's a very interesting question, and I knew that would come up because I know from some of you know I've been to Saudi quite a few times, and I know that SRAs are not available there, and I kind of understand the politics why. But so I tried to figure that out, and I could find nothing about whether HIPAAs are positive. I believe they are. And I believe they have a similar rate of positivity as SRAs, but I do not know that. I need to find that out. I'll actually ask Ted that question. Maybe I'll send it to Ahmed the answer, what Ted says. But after this, I'll send Ted an email and just ask him whether HIPAAs are positive in VITT. I think they are, but I could not find anything on that. I did have a look.
There have been a couple of questions again about post-discharge VT prophylaxis for COVID patients. Is there a group of patients that you may consider home prophylaxis post-discharge?
Yeah, Yes and no. I would consider post-discharge prophylaxis in a patient who I would consider it whether they had COVID or not. So no, a person who's going home who's still very immobilized, a patient who has other ongoing risk factors, a patient who's got immobilization, they broke their leg while they're in the hospital. But for run-of-the-mill, patient comes in with hypoxia, intermittent desaturation, they're in the hospital for 72 hours, their hypoxia improves, they're walking around the ward, and they're discharged. I wouldn't put that person on post-discharge prophylaxis. Post-discharge prophylaxis in the world of thrombosis is a bit of a religious thing. Some people believe in it, some people don't. I don't believe in it.
Right.
What I think we all agree on is the rate is really low of thrombosis.
Right. Yeah. Another question regarding the D-dimer. During the outbreak last year, every institution, I would say, was coming up with different guidelines. And one of the institutions that the D-dimer was used was basically using arbitrary cutoff points and deciding upon that, switching from prophylactic to therapeutic doses of anticoagulation. Have you come across any data on that being published or any evidence behind that?
Yeah, that's a great question. So there is now evidence. So the study that I presented, that the platform trial, Ryan Zarachansky's trial, which is only available as a preprint, not as a peer-reviewed paper, looked at low versus high D-dimer in both critically ill patients and non-critically ill patients, and basically it didn't matter. If you were a non-critically ill patient and you had a really high D-dimer, your risk of bad things happening was similar to as if your D-dimer was elevated but not really high. And it didn't appear that if you were looking at that, their recommendation is that patients who are admitted to the medical unit with COVID-19 should receive therapeutic dose anticoagulation irrespective of their D-dimer, because the heparin appeared to have a beneficial effect both in patients with a high D-dimer and patients with a not so high D-dimer. So I agree with you completely. D-dimer testing was being done willy-nilly because people thought if the D-dimer was higher, that was a marker of more severe disease. It may be a marker of more severe disease, but it's not a really good marker for progression, and it's definitely not a marker for which interventions you should use.
And in regards to the ICU patients, with the other papers, there was another study in the state that combined 3 different trials looking at critically ill patients who were in the ICU, where it showed that no benefit. Is it probably the reason that it was already too late for these patients? They were too sick to benefit from it?
No, it's probably, so it's interesting. I put one slide in about that it's actually probably that they had such a high rate of bleeding that the bleeding swamped the therapeutic benefit.
Okay.
So there's no reason for therapeutic anticoagulation not to reduce the risk of DVT and PE in critically ill patients. It's just that they have such a high rate of bleeding that the bleeding overwhelms the beneficial effect.
Okay. Okay. Back to you, Ahmed. Thank you very much, Dr. Carr.
Thank you very much.
Excellent. So, Prof. Gary, any comment or questions?
Indeed, thank you very much, Professor Crowther, for this interesting presentation. We learned a lot, and it's a continuing process. You pointed out, day by day, information will change, and we'll keep working together. I would like to thank our eminent Professor Crowther, our speaker, and I would like to thank Stago for hosting this presentation, as well as Specialized Vision for their excellent participation in the technical support. Thank you very much for all the audience and for all panel of experts. Good night, everybody.
Thank you very much, everybody.
Thank you. Thank you so much.
Thank you. Have a good night.
Thank you. Bye now.
Good night.